Good afternoon, everyone, and welcome to the COVID-19 2.0 Health Literacy Echo for Medical Providers. It's brought to you by Health Confianza, a collaboration between the UT Health San Antonio and the San Antonio Metropolitan Health District. Thank you very much for making this one of your priorities today and join us in our session. I would like to mention that we are recording the session to share it later, but your names will not appear in the recordings. My name is Raquel Romero. I am so glad to see you, and I hope you and your family doing well. I'm gonna be the ECHO facilitator for the session today, and we have a lot of information to cover. I will share some guidance first and directions from the ECHO IT about the audience and the audio connection. Please stay muted unless you are speaking. To unmute, you can use the *6 on your phone, or you can use the microphone icon in the computer, which is located in the left side of your screen. If you have some issues with the connection or with the audio, you can add your comments in the chat box. You can also send a private message to your ECHO IT. And we promote interaction in our sessions. And if you're able and comfortable, we invite you to join us by video, especially in the discussion part of the session. And also invite you and encourage you to add your comments and your perspective and your feedback in the chat box. You can also reach out to us after this session by email. And please remember that no personal health information is allowed when discussing cases and scenarios. This is a large group. Thank you so much for joining our session again. And for to keep and maintain our attendance records, would you please use the chat box and add your name, title, contact information, and organization. This is of our attendance records. Health Confianza is a county-wide collaboration to improve access and use the COVID-19 health information in Bejar County. With that, I would like to use this space to introduce our COVID-19 health literacy echo team, and I would like to start with Dr. Bergen, lead specialist and moderator for our session today.
Hi, I'm Dr. Ruth Berggren, professor of medicine and infectious disease specialist at UT Health and a proud member of the Health Confianza team. I see that Santa Claus has just joined us, also from Health Confianza. Welcome.
Well, I would use that as a connection to Dr. Rosenfield.
Hi, everyone. Sorry, I'm running a little bit late, but happy holidays to everyone. Jason Rosenfeld, Implementing Director of Health Confianza. Wonderful to be with you again today.
Thank you very much. We have for the session today, Dr. Wu as a panelist.
Hi, Juna Wu, City of San Antonio Metro Health Medical Director. Thanks for having me back with you today.
Thank you very much. And then have didactic speaker, Dr. Barton.
Hi, so I'm Tess Barton. I'm Associate Professor of Pediatric Infectious Diseases at UT Health San Antonio, and I'm delighted to be here.
Thank you very much. We have for a case presenter, Dr. Sabat.
Hi, everyone. I'm Joel Sabat with the Reach Center.
Thank you very much for presenting the case today. And thank you all for being with us. I would like to say thanks to our ECHO team for the coordination of these sessions. ECHO stands for Extension for Community Healthcare Outcomes. This is a model of learning opportunity and telementorship. And the goal is to bring the knowledge when is needed, where is needed, and to build community capacity for delivering best practice. And these sessions are possible because of you, because of your support and your feedback. Towards the end of the session, our team will send you a link for an evaluation. Would you please take a moment and follow up the instructions and complete the session? Your opinion, your feedback is very, very important for us. We're always looking for invite practices, organizations, and providers to be part of this learning community. If you know somebody that can be interested in these sessions, please send the information to us. We want to be able to contact them and provide the information about the ECHO. And please visit our website to learn more about the ECHO model and ongoing ECHO sessions. For this ECHO series, we offer in the CME, the CNE, and ethics continuing medical education. Please obtain those credits by follow up the instructions in the chat. UTECHO will post this in the chat later. But the activity code for today is 10092 389. Finally, I would like to mention that ECHO is all teach, all learn environment. So we encourage you to share your experience, your questions, and your insights in our conversation today. Be part of this learning opportunity. With no more from my end, I would like to give this space to Dr. Barton for our didactics today. Thank you very much. Dr. Barton, on your time.
Great. May I be able to share my screen?
Yes, you should be able to.
Okay.
Yeah.
Great. Oh, I don't want to show that slide, that version, right?
It looks great. Yeah.
Yeah, it looks
Okay.
very good. Yeah, thank you.
Great. So, so this is going to be a bit of an update of some information that I previously given about post-COVID syndromes or long COVID. I, of course, as a pediatrician, am going to be focusing on children, but I think that the concepts and much of the information is certainly applicable to adults as well. So I have no conflicts of interest. I also am just going to say that I'm not a PM&R specialist, nor a cardiologist, nor a neurologist, nor a psychiatrist. And this is a very multidisciplinary health condition. So that ideally would involve all of these types of domains. So today we'll go through what the immune response to the SARS-CoV-2 virus or COVID looks like, and how that immune response may contribute to the complications that we see from the virus, and exactly what long COVID is, and how that's defined, and what are some strategies that can help to facilitate recovery from this syndrome and other post-viral syndromes. So like, as with many other viruses, our immune response to COVID-19 infection involves a combination of cellular responses through our cytotoxic T cells, attempting to kill infected cells, as well as B cells releasing neutralizing antibodies. And both of those components are really required for controlling the virus and for clearing it from the body. So what we sometimes see with severe COVID infections is that when the cell-mediated system gets involved, there is a massive release of cytokines, and that cytokine release creates inflammatory responses in the lungs that can lead to severe respiratory disease. And in some cases, it's been postulated that persistent activation of those cytokine release systems can be inappropriate, right? Because anytime you have an infection, you should ramp up your inflammation, and then as your infection goes away, your T cells should jump in and regulate your response and downgrade your response so that you don't remain consistently inflamed. And so in some individuals, they may have this massive inflammatory response and then not downgrade it appropriately, and that can potentially lead to prolonged disease manifestations. There hasn't been a lot of evidence for the persistence of viral infection itself, like the virus integrating or the virus staying, that the sort of sequelae following an acute COVID infection seem more likely to be related to inappropriate prolonged immune activation. So I'm not going to dwell on the specific results or the specific cytokines or the specific things that may or may not be prolonged, because there's actually quite a bit of variability. But just to say that there are studies, including this one that I've chosen to show, that demonstrate sort of abnormal levels of certain cytokines up to many months, and in this particular study up to 8 months, following acute COVID infection, even those with mild infection. And so this is a study where they compared levels of certain cytokines in people who had prolonged symptoms, being identified as sort of the long COVID group, people who had COVID but who did not have long COVID, people who never had COVID, as well as people who had other coronaviruses, because there are actually many other coronaviruses besides COVID. And so the long COVIDs are the ones in red. And so you can see that for several of the cytokines, there were significantly higher levels many months out of some of those, including some of the interferon gammas and IL-8. And so with the postulation that, this is a sign that the immune system is being abnormally persistently activated and inflamed when it should have calmed down by now. So I did say that there's not a lot of data that suggests that there's persistence of actual virus, but I did find this, this one study. And when I previously presented this, it was sort of a preprint, but it actually has been peer-reviewed and published in Clinical Infectious Diseases earlier this year. And this was comparing adult patients who had been classified as having this post-acute sequelae of COVID or long COVID as PASC, and we'll get into that in a bit, versus those who did not have persistent symptoms. And they found in about 60% of them that they were able to detect spike protein antigens some months after infection. So it's still not clear exactly where this is. Is this, is this persistence of antigen that's been, integrated and being produced? Is this active virions? That's not exactly known, but it does suggest that for some people, there could be perhaps an inability to clear the virus and persistence of the virus itself that could lead to prolonged symptoms. So we know about many of the sequelae of COVID infection itself. So with more severe, and even actually sometimes you see these sequelae in people, we see this in children actually, who had very mild or completely unimpressive acute COVID infections, but who subsequently develop a complication of their COVID. And the most important of those, especially related to kind of thinking about prolonged symptoms, are thromboembolic complications. So these are things like strokes or myocardial infarctions or deep venous thromboses, myocarditis, which is inflammation of the cardiac tissues or the heart muscle, as well as unmasking or triggering of autoimmune diseases, which of course are also diseases of persistent immune activation that is inappropriate. I like presenting this study because there aren't very many. All the studies of like myocardial involvement in children are primarily in children who develop like obvious myocarditis or symptomatic myocarditis. And so we don't have a lot of, children are different from adults in that they generally have very healthy hearts. And so we see a lot of cardiac complications in adults, but of course the adults are older and have coronary artery disease and, other things that may be impacting their heart health. And I like this study, even though it's not a great study, because this was an observation of Big 10 athletes, right? So these are college athletes who are, should be kind of in the peak of health. And early on in the COVID pandemic, they, we weren't really sure exactly what the effects were going to be. And in order to return, and if you recall, like sports teams were doing like weekly testing of the teams, and games were getting canceled because somebody tested positive. And so they were required to undergo a battery of cardiac testing before they were allowed to return to play. And so these were healthy college students who were just, had COVID and underwent routinely a battery of tests. And so they ended up having about 9,000 college athletes who tested positive for COVID, 2,000 who tested positive for COVID-19, and then underwent their cardiac evaluation. And essentially what they found in this study is that 2% of like healthy college athletes who had a COVID infection had evidence of myocarditis, based on the cardiac MRI or their enzymes or some of the other tests that they put them through. And most of them had mild or no symptoms with their COVID infection. They were incidentally identified through routine surveillance testing. And so I think that this gives us a lot of information about, how much COVID impacts the heart in otherwise healthy people who may not be severely ill. Like, this is a very sort of cardiotropic virus. We also know this is kind of a neurotropic virus. And so there are a variety of different neuropathogenic mechanisms of the way that COVID impacts our neurologic systems. And that can be either a direct invasion of viral infection into neurons and into the olfactory bulb, giving us the, characteristic loss of smell. They can be, vascular with strokes and endothelial damage. You can have encephalitis. You can have myositis that can be related to the cytokine storm and excessive inflammation and peripheral neuropathies. We've also seen plenty of cases of Guillain-Barré, like demyelinating syndromes following COVID-19 infection. So there's many ways that the virus itself can impact the nervous system. So long COVID, which is what's generally called in kind of the lay language, and because it's easier to say, essentially just means a variety of different persistent symptoms or effects weeks or months after having an acute COVID infection. Some people will call this a long hauler. The official name that I think people have finally landed on is this post-acute sequelae of SARS-CoV-2 infection, or PASC or PASC. But that's kind of a mouthful. And in pediatrics, we call it PPASC, with a little p for pediatric. But this is very similar, and this is not the only post-viral syndrome that we have. We have post-viral fatigue syndrome, which is very commonly associated with Epstein-Barr virus infections, as well as other post-infectious fatigue syndromes, such as what we see in chronic Lyme disease, is really a post-Lyme disease. Chronic fatigue syndrome, myalgic encephalitis. You can throw fibromyalgia. You can throw POTS. There's all sorts of different syndromes that kind of fall under a similar umbrella, which is that you get an infection or something that triggers your immune system, and you end up with this chronic symptomatology. And so the post-acute sequelae of the PASC symptoms, the definition that we have with the NIH is symptoms that have an onset or persisting more than 4 weeks after your acute COVID-19 infection, that includes fatigue and a variety of other symptoms, but prominent among those symptoms should be what's called post-exertional fatigue. And post-exertional fatigue is where you feel fine one day and you're like, okay, I'm gonna go to the grocery store and I'm gonna go to school or I'm gonna go do my activities. And then after you've done what would otherwise be kind of normal stuff, you're profoundly fatigued, oftentimes for days. And that's that should be a characteristic feature of this syndrome. It should be intrusive into your daily activities and not explained by other conditions, which is honestly the whole point of this presentation. So the WHO also has a definition for prolonged post-acute COVID, which is 3 months, but otherwise is more or less the same. And so these symptoms that you see, there's a lot of overlap with the other consequences of COVID-19, and in particular the neurologic consequences. So I mentioned, so we've been early on in the pandemic, one of the first things that we saw being described was this like brain fog, right? So people who felt kind of cognitively funny, they weren't feeling, they weren't feeling like they had good executive functions, the dysautonomia, things like orthostatic hypotension, or changes in your temperature regulation, pain syndromes with myalgia, neuropathic pain, as well as exercise intolerance. And that could be related to pulmonary disease, that could be related to cardiac disease. All of those things kind of come together. And so long COVID really has an overlap with all of those. And so these are the things that become important to distinguish when you have a patient who's having persistent symptoms after COVID. So are there ways that we can predict who's going to get long COVID? Well, the answer is maybe. So certainly The prolonged symptoms have been described more commonly or more frequently happening in people who have severe disease, who have ICU stays, who have bona fide pulmonary emboli or myocardial dysfunction. And again, because these are things that impact your oxygen handling, your blood delivery. And so you would expect that you might have decreased exercise tolerance or decreased ability to handle additional stress loads on the heart or the lungs. And so not surprisingly, these are potentially predictive factors for PASC. And so in children, however, most children don't have that. Most children have a very mild COVID infection, and yet we still see this in children. So there are many studies looking at what's the actual like incidence of PASC in children and adolescents following COVID, and there's a wide range of reports from anywhere from 8% to 58% of children experience some sort of long COVID symptoms. However, and I've listed there many of the studies that have been published. Most of these are uncontrolled observational studies. And the problem with uncontrolled studies is that many people experience anxiety, depression, other illnesses, lack of control of their diabetes or whatever, like lots of other factors that led to people having, general COVID malaise during the pandemic that may not officially be sort of PASC or long COVID. And so it is important to have controlled studies. And so the controlled studies do consistently show that there are higher incidence of prolonged symptomatology in children who get COVID compared to children who don't get COVID. But there's a wide variability from like 1% of them developing long COVID to 50%. So it's kind of all over the place. My favorite of the studies is actually this Danish cohort because in their system, of course, this is a centralized, nationalized, socialized, healthcare system where all of the hospitals and the clinics are all linked into the same, medical documentation, EMR or whatever, and so they're able to connect labs that are done somewhere with other things. And so, in this was a study of about 15,000 children, retrospectively in Denmark who developed COVID at some point, and they compared them to 15,000 who never tested positive for COVID in the healthcare system. And they defined the long COVID as certain symptoms that were lasting more than 4 weeks. And essentially they found that 25% of those with COVID reported symptoms, but 22% of those in the control group reported prolonged symptoms as well. Now, because they had such a huge cohort, this was statistically significant. But you can see that a lot of people, develop prolonged symptoms, even if they didn't have COVID. And interestingly, of the ones who had long COVID, 7% of them were asymptomatic during their acute COVID infection. So they're, you don't have to have severe COVID to get it. Not surprisingly, most of it was in teenagers. So the highest incidence of long COVID in their cohort were actually in the teenagers, the 15, 16, and 17-year-olds. Up to 50% of the 17-year-olds developed prolonged symptoms. And this is not surprising for those of us who deal with chronic post-viral fatigue syndromes, because it's almost always the teenagers, sort of the type A personality, cheerleader, pro athlete, straight A student who develops prolonged symptoms following their viral illness. And that's very similar to what we see with long COVID. Okay, moving on from that, what do we do? So when we're faced with a patient who comes in with these kind of prolonged symptoms, because we know that there are actual other potential physiologic sequelae of the virus itself, it's always important to think about cardiomyopathies, make sure they didn't develop a cardiac problem during their acute COVID that they're having persistent symptoms from, rule out thromboembolic complications. We usually will screen for autoimmune diseases because they look very similar, and as well as thinking about kind of mimicking diseases, things like hypothyroidism that was previously undiagnosed, depression, of course, and doing mental health assessments. So as far as like, do we order a battery of labs? There are, there's a big push among some patient advocacy groups and where they really want to get their immunoglobulins checked, they want to get all of these things checked. Frankly, the literature shows that there's really not major differences in most of the routine inflammatory labs in COVID, in long COVID versus not long COVID patients. And so there may be of limited value. Many times we do them because they are part of looking for autoimmune diseases and other things, but they're most often normal or not particularly different than the general population. What are different are sometimes some of the mental health assessments that we can do, and so this study found that there were that there was a higher odds of PASC if there were high scores on a couple of different health assessments at sort of the baseline visit. And so those two that people might find useful, one of them is this SF36, which is called the Short Form Health Survey, and it's available for free from the RAND Corporation at this website. And the other is this General Anxiety Disorder questionnaire 2-item scale, which is very non-specific, but people who score that kind of when they come in may have a higher risk of having of long COVID. I don't know how useful these are in clinical practice, because I often find that getting my extensive history it gives me all the same information, but they are tools that are available that people are using in their long COVID clinics. There are also guidelines for that have come out, or guidances, not guidelines, but guidances that have come out for ways that you can deal with that. And there are two that I want to mention. So this one, which I think is worth a download, is really a multidisciplinary consensus guidance through the PM&R kind of focus on dealing with fatigue and post-acute sequelae. And really the mainstays of this are to set achievable goals for your patient. So those of us who deal with these like long post-viral fatigues are used to doing this, where you have the patient who they used to be, the straight A student doing all the activities and everything else, and now they can't do anything. And they, they just want to lay in bed all day. And so sometimes setting very, very small daily or weekly goals to kind of gradually increase their activity. Today, you're going to get up and you're going to change out of your pajamas into your clothes. That might be their goal for that day, because that might be what they can handle. And then once they're doing that, then you can add on new goals to kind of gradually increase their activity, but something where they don't feel like they're a failure if they don't achieve that. Focusing on relieving specific symptoms, whether it's their headache or their dysautonomia, or maybe their anosmia. And improving their overall kind of physical, mental, and social well-being. Probably one of the most important things that we often overlook in our own lives as practitioners is our sleep-wake cycle. And so this is something that's frequently disrupted in people who have PASC or other post-viral fatigue syndromes, is that they sleep all day, and then of course they're not tired at night. And so then they're up at night, which only perpetuates an abnormality of their circadian rhythms. And so sometimes doing things that will, working on sleep hygiene, occasionally sleep aids, things to try to help them to re-enter a restful sleep cycle are very important in recovering sort of normal physiologic function and decreasing fatigue. And also kind of working on supporting them and restoring what's normal. So part of the psychological support of people who have these is recognizing that, yes, you feel bad, you're not making it up, and we believe you. I believe that you feel bad. I don't think that you're faking it. This is a real thing, and it's okay, and it's not going to last forever, but I'm also not going to make it better immediately. Let's work on it in steps. And sending somebody to physical therapy to help them kind of identify small things that they can again achieve and do and build to try to kind of rebuild themselves back to their normal self. So in November, there was a publication in Pediatric Annals which was an overview of, there were back-to-back articles, one on the physiology and one on kind of guidance on what to do with pediatrics. And I think this is actually very comprehensive, and in some ways more, it's shorter and more comprehensive than the PM&R guidance. And it has, I'm not going to go through all of these things, but it has suggestions for what the primary care doctor can do with somebody who was diagnosed with COVID-19 and now has prolonged symptoms, including some basic screenings, olfactory retraining if they have loss of their smell, referrals that they should make. So olfactory training, just because I had to look this up because I thought, what's that? Is kind of a cool thing. It's actually been studied in a variety of different post-viral or post-neurologic syndromes, including after strokes. And it's currently in trials in many COVID-related things. So that's just sort of a listing of all the trials that are ongoing with olfactory training. And it's essentially these panels of aromatics that the patient sniffs, like constant sniffing for 20 to 30 seconds, a couple of times a day. It's long-term, but to try to retrain their olfactory nerve to recognize different kinds of smells. Kind of neat. Anyway, but the same article has information on, like, if you're a PT or a PM&R doctor, like what kinds of things can you do? If you're a psychologist, using different anxiety management strategies, using other things like that to try to address the needs that the child is having. If a cardiologist, screening for cardiomyopathies, if they're presenting with palpitations, looking for dysrhythmias, if they have chest pain, looking for myocarditis, and ways of dealing with dysautonomic, hypotension and things like that. Neurologists, pulmonary doctors. So it's got kind of in the different domains, depending on what the patient's symptoms are, what kind of testing or what kind of strategies would be useful in trying to figure out, do they have an underlying problem that needs to be addressed in a different way? And are there other things that we can do to try to restore their function back to normal? And it goes on and on. So, so this is the article, which is a review of current evaluation and management strategies in pediatric post-acute sequelae and pediatric annals. So I suggest people, if they're interested, to look that up, because I do think it's useful. So are there any other things? Are there any other studies going on for therapeutics? So there's an Italian study group that's like super into arginine and vitamin C, and there have been multiple studies in acute COVID. And of course, they now have a study that's been published looking at the use of these supplements for past or for prolonged symptoms, and demonstrating some modest improvements in walking distance and hand grip and some of these measurements in patients who are getting this. It's, I don't know how reproducible this is, but these are things that many times patients want something, and they want something to do, and are likely reasonably benign, and might, if it may have some benefit, it may not, remains to be seen. There have been studies of intranasal mometism, which actually doesn't show a significant difference in return of smell. But I will say that the study that they did have a 22% reduction in anosmia in those who were in the mometism group versus the placebo group, but the study was powered to detect a 45% difference. So they just weren't able to reach statistical significance in the way that they designed their study. So for some people who have that type of symptom, it may be something to consider, especially if they also have allergies and other things. So when do they get better? So unfortunately, it's not fast, and the time to remission is really going to be on the scale of months, and letting patients know that that's what's to be expected, so that they're not thinking that, oh, you're going to do something and I'm going to be better by the time I see you next time. No, it's long and it's slow. And again, in the Danish cohort, again, it was long and it was slow. although most of the kids actually recovered in less than 6 months. Unlike adults who often may take longer, there were still about 20% of them at a year who still had symptoms. So this is something that giving your patient realistic expectations of how things are going to go can help them psychologically to be prepared for what they're dealing with. So with that, I'll close, and I have a list of references. I had a case built into my slides, but I'm going to skip it because we have some other cases and I want to be sure that we have time to talk about those. So let me see if I can stop sharing.
Thank you for an excellent overview, Dr. Barton. I am monitoring the chat to see if there's going to be questions. And so I would like to invite our audience. I'd like to remind everybody that this is an all teach, all learn environment. We do have some cases for you today, and we want to make sure we address your questions first before we go to the cases. And in that spirit, I'm going to launch a question for Dr. Barton. So it's kind of twofold. One is, what are you seeing personally? Are you getting a lot of referrals as an infectious disease specialist? We heard you loud and clear about how of clinical problem that requires a team, but are you seeing a lot of cases? And then would you speculate a little bit about how this is impacting primary care outpatient pediatric practices in the near and long term, since it seems like there's a surprising number of cases? Thanks.
Sure. So, so I'm definitely seeing these. You know, there are some centers around the country that have set up these like long COVID clinics where it's like a multidisciplinary clinic with PM&R and cardiology and infectious disease and psychology. And unfortunately, we don't have that, but certainly, you know, myself and the like immunology folks do see quite a few other like post-viral fatigue syndrome. So I've gotten many referrals for you know, suspected long COVID versus, you know, is it rheumatic fever or pandas or, you know, other kind of post-infectious things. So I think that, you know, pediatricians are dealing with this, and unfortunately, you know, I think that because these illnesses are very time consuming, right? They're time consuming to talk to the patient about them. And that I do think that we, you know, kind of glean over some stuff or call it allergies or whatever. But it certainly exists. And I think that the simple, you know, recognition by a pediatrician that it's okay that somebody's having symptoms after their COVID for a while, and that's not uncommon. You know, themselves is like, for, you know, kind of recognizing that I think is important. But definitely, you know, pediatricians' offices are seeing them. It's always hard to say what's the impact, because at the moment, like, everybody's impacted by snotty children coming in with other respiratory viruses and like overwhelmed constantly with, you know, the broncholytics that are walking in the door, but they're definitely coming in.
Thank you for that. And I'll just mention to our audience that we are planning to have a listening to long COVID echo series that will be starting very late February, early March. And we'll have several sessions, including probably another one on pediatric long COVID. So stay tuned for that. I see a question from Sarah Jo Wagner, who asks, is there information on health outcomes for folks who had long COVID and then are later reinfected? Is that one you can answer for us, Dr. Barton?
Yeah, so there, I don't know of specific studies, but I would say that anecdotally and just from reading, like, you know, lay literature and like news reports and things like that, that there does seem perhaps that people who already have long COVID and then get reinfected, often report having an exacerbation or a worsening of their long COVID. And that would make sense, right? Because if you have an immune mechanism that's a little bit out of control and making you feel bad, and you reactivate your immune mechanism, that you would expect that you might have a flare of your symptoms.
Yeah, I've seen data that suggests that with each reinfection of COVID, your risk of long COVID increases. So while one might hope that having multiple COVID infections would build up your immunity and then somehow be protective, so far, the data don't suggest that repeated COVID infections protect you in any way from long COVID. In fact, the only things that really can protect you from long COVID, and I'm citing adult data, and so Dr. Barton can tell me if there's pediatric data, but getting vaccinated can prevent the risk of long COVID, actually reduces the risk of long COVID by as much as about 26%. And also in adults who need Paxlovid for various indications, in those people, the use of Paxlovid, the antiviral in the outpatient setting, can also reduce your risk of long COVID. I would like to turn now to our first case.
Dr. Berger,
Yes.
I see a hand for Veronica Atier.
Oh, thank you. All right. Ms. Veronica Atier, please state your question.
Oh, thanks very much. And I'll try to be very brief. Two things. Have you looked at CD8, CD4 numbers in the pediatric patients? Because most of those studies have been done in adults. But I see more and more MDs communicating and pediatricians communicating of these low numbers and NK cell numbers as well. And the second one is we've been starting, or we're trying to look into microclots. I don't know if you have a look to the microclot studies. And we actually just had a very preliminary study here done, because we are only trying to set up the technique that they are using in South Africa and in UK. And it was actually very striking, very, very striking to get that into adolescents.
So I have not seen specific data for children regarding, lymphocyte subsets and alterations in those. But definitely the kind of microangiopathy and microclots that can happen with COVID, and then causing subsequent pathology, have definitely been demonstrated in children as well.
Thanks.
Thank you. I'm seeing a question from one of our panelists, Dr. Wu, who asks, when the vaccine first came out, some people with long COVID said the vaccine improved their symptoms. Others said they worsened. What's the current state of knowledge?
Do you want me to address that, or somebody else?
Sure, you can take a stab at it. My answer quickly would be we're still evolving in the state of knowledge.
Yeah, so I think the symptoms following vaccination are all over the place, right? When some people are like totally fine, and other people feel wiped out for a week, and so you do wonder about people who have long COVID, and if you're going to sort of re-trigger them by giving them vaccine. And that certainly has been observed. And in fact, we just had a very, very unusual case in an adolescent that we decided to defer giving him further vaccine, because he didn't have that. He was actually not vaccinated, but when he got COVID, he actually had an MI. And then when he got COVID again, he did it again. And in between times was fine. But I was a little bit hesitant to make him produce a lot of spike protein, not knowing exactly what his response was going to be.
Oh, understand. Thank you. Questions are piling in, so let's take a few more. Beth Wickman asks, does pacloslovid or monoclonal treatment decrease the risk for long COVID? I'll take a stab first. There is recent data, or recent reports anyway, that Paxlovid can reduce the risk of COVID by long COVID by about 26%. And that's actually data from a very large study at the VA with over 56,000 people, in which 9,000 and change got Paxlovid compared to everybody else who got no Paxlovid, and there was a 26% decreased risk of long COVID in veterans who got assigned to Paxlovid. Well, it wasn't a randomized study, but historical. The ones who got Paxlovid had a reduced risk of long COVID. Monoclonals, well, unfortunately, current monoclonals are not very effective against the circulating viruses. So the answer is right now, probably no impact on long COVID for monoclonals. Not sure if previous versions of the virus that were circulating might have had a less risk of long COVID with monoclonals. All right. Dr. Dean has said school nurses may be the only medical profession some children may come in contact with during the year. Access to medical care may be limited, and non-medical determinants of health may obstruct access. Less obvious symptoms in young children may be missed by parents. Are school boards and school nurse organizations aware of symptoms of fatigue, exercise limitation, and delays in school performance? Dr. Barton?
So first of all, I want to say like amen to that. And then because that's absolutely true. So I think that, you know, school nurses and school health officials often are aware in the sense that, you know, there often are guidances. So there are guidances for like return to sports and things like that. And those have recently been kind of updated actually by the AAP. And so I think that they are aware when it comes to those. Like other systems, they're also, of course, you know, limited in like, do they have the capacity to deal with it when they see it? So I don't know how adept they are like in our local communities of acting on that. I do know that I haven't gotten any referrals from schools or from school nurses for children that had, you know, were falling off in their sports performance or expressing
Thank you.
problems.
I'm wondering if Dr. Junda Wu, who is our San Antonio Metropolitan Health Medical Director, would like to comment on this, since I know she has interactions with school nurses.
No, I mean, I other than the amen, I agree with Dr. Barton. I don't have anything. Thank you.
Thank you. All right, I'm watching the time, and we do have two cases. And Dr. Savat, there was a late-breaking pediatric case that came to us. And so I'm going to ask, with your gracious permission, to go to the pediatric case first. And if we still have time, we'll go to the case that you very kindly submitted to us. This case came to us from a pediatric hospitalist, Dr. Rachel Pearson, who's well known to our hub team and has been a panelist here. She writes of a 13-year-old female who was admitted to the hospital for episodes of eye fluttering and altered consciousness. These episodes lasted around 2 minutes and were followed by 15 to 30 minutes of feeling confused, happening both at home and school. They had happened several times in the last 2 weeks and seemed to be increasing in frequency. No other abnormal body movements, no loss of consciousness, no falls. After one episode like this, the mom gave the teen her Apple Watch so she could keep an eye on her heart rate. And mom noticed that her heart rate is intermittently up to 180 and will often be between 120 and 150. When asked, the girl says she has felt her heart racing on and off for the past several months, worse when she stands up and comes out of nowhere. This admission, EKG and 24-hour EEG are normal, though she did not have an episode during the EEG. Her neurologic exam is normal. Orthostatic vital signs notable for a sustained increase in heart rate by 35 points upon standing, no changes in blood pressure. Relevant past medical history is a concussion during soccer 6 months ago when she had brief loss of consciousness and vomiting for a couple of days, but a normal head CT. She does still get intermittent headaches not associated with the heart racing or the episodes of altered consciousness. She was admitted to the hospital after concussion. She had tested positive for COVID. So there was documentation of an actual COVID infection. She had cough, but was otherwise asymptomatic. So what Dr. Pearson would like to have us focus on is the mom's question. So let's land on that first off. Mom wants to know if this could be long COVID. Dr. Wu?
So I'm not a pediatrician. I would really like to hear Dr. Barton answer it. Sorry.
All right, thank you. Dr. Barton.
So I think if I were seeing this patient, I would say that is it possible that this is, long COVID in the sense that you have some symptoms after COVID? Maybe, but there are several red flags here for other sequelae, either of the concussion or of a COVID cardiac disease, or of just an underlying thing that the COVID was unrelated to. So, certainly there are features here of POTS, which is this postural orthostatic tachycardia. And that is something that's frequently seen in the spectrum of post-viral fatigue syndromes and myalgic encephalitis. But this episode of like heart rates of 180 associated with altered mental status kind of smacks of an arrhythmia that was not, just because something wasn't detected on a single EKG doesn't mean that that's there. And so before I would call this long COVID, I would absolutely have this child undergo a more comprehensive cardiac evaluation to make sure that that they're not dealing with a significant arrhythmia or a cardiomyopathy. Similarly, the eye fluttering and altered mental status does make you worry a little bit about some sort of partial seizure activity, especially for following concussion. And so I think that there are several red flags here that make you that I think require a little bit more workup for actual neuropathology or cardiac pathology, which may or may not be related to the COVID.
Right. If I'm not mistaken, I'm trying to remember the case exactly, but it sounds like it had been 6 months since her COVID infection when she really presented with this escalation
Right.
of these various symptoms. So that seems like a long lag.
It does. And most of the people who develop the sort of past or long COVID symptoms, they develop those symptoms during their infection and they continue. Or they have an onset. In our definition, actually, the NIH definition is onset within 4 weeks. So, so if this was something that was fine and then 6 months later developed a problem, we wouldn't consider that long COVID. But again, what did COVID trigger, a myocardial event that now has sequelae? That's important to assess.
Right. Right. Complex. All right. Let's bring the case back up because I think there were a couple more questions. All right. I think we've kind of talked about question 2. For primary care physicians out there, would this child be appropriately first referred to infectious disease, PM&R, or cardiology? Would you want to see this child in your practice, Dr. Barton?
I mean, I'm always happy to see them, and I do get these kinds of referrals where they think that the pediatrician has basically made referrals to all of the above, and I'm more than happy to go through those. I often find the infectious disease people are often kind of while not officially the medical home, we often are the sort of coordinators of multi-specialty care, because we're used to that with our like HIV patients and others. And so, I'm also happy to kind of facilitate those. But I would say in this particular case that if I had to prioritize what I was going to spend their copays on, it would be the cardiologist.
Okay, thank you for that. And I just want to remind everybody that we had 2 excellent references that were pointed out to us. One was from a PM&R journal, and I noticed that Dr. Monica Verduzco Gutierrez, our very own chair of PM&R, is an author on that paper. Dr. Wu put a link to the PM&R guidelines. Thank you, Dr. Wu, for doing that. And then also that Dr. Barton put a reference to the November 2022 Pediatric Annals, a paper which talks about first steps for basic screening, which I think should be very helpful to primary care doctors. All right, let's quickly go to the second case. And Dr. Savat, we have a few minutes if you want to take it away. This is a non-pediatric.
It's not pediatric, and originally, this was mostly a clinical case, but since this is a health literacy echo, there is a health literacy component to this that I didn't really raise here. So we can talk about either one of those. I don't know if we have time for both, but I can present the case and we can go from there. So it's a 66-year-old female who had COVID-19 for 2 weeks. That's history of chief complaint. On Thanksgiving morning, she developed a low-grade fever, maximum temperature of 99.9, nasal congestion, headache, and a scratchy throat. She did a home test for COVID, which was positive, but actually was very faintly positive, and this may have to do with the health literacy thing. And so a repeat home test purchased from a different pharmacy, a different type of home test, was a little bit more convincingly positive. She went into isolation and started to take Paxlovid that evening. Over the next few days, the sore throat got much worse and the nasal congestion increased. By the 5th day, her symptoms improved, and by the 7th day, they had markedly improved. She did not retest at that point. 2 days later, her nasal congestion recurred and she began to sneeze. She had some fatigue, anorexia, and distorted sense of taste, but no fever or sore throat, but did have some fatigue. So she did another COVID test on day 13 and it was still positive. On day 15, she tested negative and felt well. She had not had COVID previously and had been vaccinated 5 times, including once with a bivalent vaccine. And she was always very careful about being in indoor public spaces. So some relevant, maybe past medical history of hypertension, prediabetes, breast cancer, et cetera. Diabetes insipidus, not diabetes mellitus. They're her meds. And so my questions were, is this a case of rebound following Paxlovid or just a waxing and waning course of COVID?
As the internist on the session here today, I'll take my stab at it. It looks, if I've understood correctly, Dr. Sabat, that the person did their 5 days of Paxlovid, and then about 2 days after the Paxlovid was stopped, they had this recrudescence of symptoms, including loss of smell and taste. I would say that is absolutely classic for what's been described as Paxlovid rebound, rather than post-acute sequelae of COVID. So that's how I'd address that. I wanted to point out that it's delightful to see appropriate use of Paxlovid. This woman had several indications for it. 1, she's over the age of 65. 2, she also has hypertension and even prediabetes. So she is someone who would be at risk for a very bad outcome of COVID-19. So this was entirely appropriate for her to get Paxlovid. And now we know that that may have even reduced her chances of getting long COVID, at least somewhat.
Do you need a negative test result in the middle there to call it a rebound, or is no test sufficient?
So based on my clinical awareness, we are not requiring that strict definition. That would be, inside a clinical trial where people are monitoring, that would be of interest. But this pattern of prompt resolution of symptoms, a lot of times people note improved symptoms within 48 hours of starting Paxlovid, then they complete their course. And then it is fairly typical that it's within a couple of days after getting off the Paxlovid that the symptom rebound.
I think I have a second question on that case.
Can we go to Dr. Cesar Garcia's question? Because I see his hand up, and it may be a question for you, Dr. Sabat. Dr. Garcia, did you have a question?
Oh, yes, ma'am. Just the question was, I tend to use molnupiravir sometimes because of drug interactions with a lot of my patients that are taking chemo or that they're on antiarrhythmic medicines. Is there data that it also helps with long COVID, and then as far as head-to-head trials, is it similar type of medicine? How similar? Because that's what I tell my patients, it's a similar medicine, but I just want to make sure.
Well, so certainly the antiarrhythmics pose problems for drug interactions with Paxlovid because of the ritonavir component. But molnupiravir is far less effective. There's about a 30% reduction in hospitalization or death from the drug. So it's better than nothing. Whereas with Paxlovid, you have an 88, 89% reduction in the risk of hospitalization or death. So they're not equally efficacious. And molnupiravir is kind of a drug of last choice if there's really nothing else you can use. Other options, if you have that drug-drug interaction concern, would include finding an infusion center that could give once-a-day infusions of remdesivir, the IV antiviral that has to be given once daily for 3 days, but there's excellent data about efficacy with that drug. So that's another option that you have. Dr. Sabat, did you want to go on and ask your additional question?
Yeah, so the second question is, are there any instances in which Paxlovid could be given for more than 5 days, say 10 days?
So that is an area that is controversial. Pfizer is not studying that to my knowledge. There have been high-profile people that took a second course of Paxlovid for their when they had the Paxlovid rebound. In fact, I believe I recall hearing that Dr. Fauci had taken a second course of it. I can't say that. I know that's correct firsthand. It's hearsay. However, the FDA has come out with a pretty strong statement saying that there's absolutely no evidence that works and that it should not be a recommendation at this time. So I suppose it's a matter of clinical judgment.
Okay. Let me just point out what I think are the health literacy issues here. And that has to do with home testing. There's the issue of false positives or false negatives primarily early on, and potentially false positives. But the actual difficulty in following the instructions and actually, I'm sure all of you have done home tests for COVID. This is not easy. It's hard to manipulate the stuff to read the fine lines. To how to even things like the easiest part is swabbing your nose, right? It gets much more difficult after that, and I worry about patients who, this patient was a nurse by background and was surrounded by doctors, so it wasn't an issue here. But what about somebody who doesn't see well or can't read the instructions or has a disability and can't manipulate the card and the liquid and the probe and this is not easy.
Thank you for that. And I see Dr. Wu has her hand up. Dr. Wu?
Yeah, thank you for that. I think there's the difficulty taking the test. There's people not realizing, as this woman did, hey, maybe I need to repeat my test in 48 hours. And there's not everybody having the same amount of access to tests and to Paxlovid. But my question for Dr. Berggren is, my understanding in my public health ivory tower is that people who don't take Paxlovid also experience rebound, and that we still have a lot to learn about this Paxlovid rebound. But can you comment on that? Thank you.
Well, I guess if you've taken Paxlovid and you have this, improvement and then resurgent, we'd probably have to call it consistent with the rebound. But if you didn't take Paxlovid and you're having something similar, that might look like you're evolving into a PASC, some sort of post-acute sequelae of COVID. So more to come on that. I'm sure that there will be reams of papers that will be written describing this. Thank you so much, Dr. Sabat, for pointing out the health literacy aspect. I'll tell you that I get people texting me pictures of their COVID tests all the time, including this week. Somebody sent me a picture positive, and I say, if you see anything there, it's positive. And I think that people do need to know that if they're symptomatic and they've got this faint positive, they should assume it's positive and behave as such, right? The important thing is put your mask on, isolate. You can repeat the test if you want, but if you see that faint positive line, please don't go infect anybody else. And if you've got risk factors, find somebody to help you decide if you need to get that Paxlovid prescription or not. All right, I'm going to turn our microphone over to my co-facilitator, Dr. Raquel Romero, and thanks everybody for sticking with us.
Thank you very much, Dr. Berggren. Thank you for the final comments. Thank you for always be our leader specialist. And thank you, Dr. Barton. Thank you very much, Dr. Garcia, for your questions, Dr. Sabat for the case, Dr. Wu for being part of our team, Dr. Rosenfield, and you all to be part of our team. Well, that was an excellent discussion, and please consider in the future sessions, submit cases or follow up the cases. This is our last session for this year, and you can learn more about the echo sessions on our website. The information about the continuing medical education and continuing nurse education and ethics as well is in the chat. Just please follow up and complete the post-survey session feedback. This is very, very important for us. This is gonna be open for 1 week. Thank you for your participation and for being part of about this learning community. I will see you next time and have a happy holidays. Thank you, Dr. Rosenfield, for your comment as well. Thank you very much. You have a wonderful rest of the day.